today we are here to discuss about the performance of an apnea test. But before we go into apnea test, I think our first thing that we need to understand is apnea test is done to evaluate somebody for brain death or brainstem death. But before we do the apnea test, we need to understand that apnea test is done only in patients where we want to document brainstem death or brain death, number one. Number two, for anybody to be brain dead or brainstem death, we need to document three things. First, they have to have irreversible coma. They have to have a clear-cut reason for why they are having irreversible coma. In the absence of a clear-cut cause, we should not proceed to do brainstem evaluation in any patient. Common reasons why somebody may appear to be in coma are extremely low levels of temperature, hypothermia, severe alcohol intoxication, various drugs including sedatives and paralytics and neuromuscular blockers that we use in the ICU, severe metabolic derangements, especially extremely severe hypernatremia, severe endocrine abnormalities, and sometimes when the patient has taken drugs that can be measured, one has to make sure that the drug levels are monitored in the blood and these levels are within very minimal limits so that they do not confound the assessment of brain death evaluation. Once we have a clear-cut cause, we have shown that there are no reversible factors causing the brainstem dysfunction. We document irreversible coma. Then we have to make sure that there is absence of all brainstem reflexes, and only if all these criteria are met do we move on to perform the apnea test. Apnea test is the gold standard to determine brainstem dysfunction or brainstem death. If apnea test cannot be done because of various reasons, then the patient needs to have a confirmatory test for brain death. We have already looked at the patient and evaluated him for the absence of brainstem reflexes. Once we have done that, I think we need to move on to doing what we call an apnea test. It is done to make sure that the patient is in apneic coma, where he does not have any respiratory efforts before we declare him as brain dead. But before we do the apnea test, I think there are certain things that we need to make sure that the patient is eligible to undergo the apnea test. If he is not in a stable condition to undergo apnea test, then you should not be doing the apnea test at all. So this is very, very important for you to understand. First, patient's temperature has to be more than 35 degrees. If the patient's temperature is less than 35 degrees, do not do the apnea test. Rewarm him, get his temperature up to 35 and then go on to do the apnea test. So the second criteria that we need to make sure is that the patient is not receiving a lot of oxygen on the ventilator, because for an apnea test we are going to disconnect the patient from the ventilator, and if he or she is receiving a lot of oxygen, then taking him off the patient from the ventilator is going to be something dangerous and life threatening, which is not what our goal is. So generally the patients have to be in less than 60 to 70% oxygen for us to be able to safely do the apnea test. And if this patient does not meet the criteria, again do not do the apnea test. The third criteria is patient's hemodynamics have to be reasonably stable. Patient may be on vasopressors, but still the systolic blood pressure should at least be 90 millimeters mercury before we actually go ahead and do the apnea test on reasonable amounts of hemodynamic support. If you are not able to achieve these things, please do not do the apnea test and stop your brain death evaluation with the evaluation of brainstem reflexes and move on to an ancillary test for confirmation of brain death as per your education modules. So as we are getting ready to do the apnea test, again I want to make sure that we are very clear that patient's brainstem reflexes have to be evaluated, and absence of all brainstem reflexes have to be very clearly documented before we go on to the apnea test. If the patient has any brainstem reflex, please do not do the apnea test. Now since we have already done the brainstem evaluation of this patient and we have documented that there is no brainstem reflex, we will go on to do the apnea test. Right now, before we do the apnea test, we want to make sure that the patient is adequately oxygenated so that when we disconnect the patient from the ventilator, he continues to have reasonable amounts of oxygenation. For that, The first step I generally recommend, and what is recommended, is to increase the oxygen concentration on the ventilator to 100% FiO2 and ventilate the patient with 100% FiO2 for a period of 5 to 10 minutes. So, the first step, we will go ahead and change the oxygenation on the ventilator to 100%. So, we have made the ventilator settings to keep the patient on 100% oxygenation so that we can pre-oxygenate with 100%. We have made sure that the patient's vitals are all stable on the monitor. Our first job is to get a baseline Abg before we go on for apneic oxygenation. So, right now we are going to show you how to do the baseline Abg. I am going to request my assistant to come and draw an Abg and get the baseline results. Thank you. So, we have the baseline Abg result here. When we have the baseline Abg, we are going to look at a few things to decide whether this patient is fit enough to undergo the apnea test. First, we are going to look at the pH 7.47. This is within the physiological limits. If the patient is extremely acidotic or alkalotic, then we do not go ahead with the apnea test unless we correct the acid-base abnormality appropriately. The PCO2 level in this blood gas is 35, which is again normal. You want to maintain a normal PCO2 or a slightly lower PCO2 before you start the apnea test. You want to pre-oxygenate and make sure that the oxygenation or PaO2 is appropriate, and once you ensure that all these three parameters are okay, then we can proceed on and do the apnea test. So, as we discussed, we have made the changes in the ventilator, made sure the patient is stable. We are going to get a baseline blood gas as shown earlier. Once we have the baseline blood gas and we have documented adequate oxygenation and a normal PCO2, we are going to proceed with what we call apneic oxygenation. We have this tubing here which can be connected to the oxygen flow meter, and we are going to disconnect the patient from the ventilator. But prior to that, I want to point out that right now when the patient is on a ventilator, his chest is going to be rising appropriately, and once we disconnect him, we are going to watch the chest for rise and see whether he's got spontaneous efforts. I'm going to disconnect the patient from the ventilator. I'm going to insert this oxygen tubing. And I'm going to give at least 6 liters of oxygen through this tubing here so that the patient's oxygenation remains stable throughout the apnea test. So, in our apnea test today, we are giving this patient 6 liters of oxygen. His saturations are remaining around 100%. Now, we are going to watch his chest for any chest rise. We are going to keep this patient apneic for a period of at least 8 to 10 minutes. And the rationale behind it is the PCO2 starts climbing by 2 millimeters of mercury every minute. So, if you wait for 10 minutes, hopefully the PCO2 rises by 20 millimeters of mercury. Our threshold is at least a 20 rise from the baseline PCO2 or an absolute PCO2 level of 60 millimeters mercury. The rationale behind this is at this level of PCO2, our brain centers should be stimulated and we should be having spontaneous respiratory efforts. However, in a patient who has got no brainstem function, no amount of PCO2 will be able to stimulate the respiratory efforts, and therefore, you will see that this patient does not have spontaneous efforts despite the fact of his PCO2 building up above the threshold value of 60 millimeters of mercury. Once this is done, our job is going to be staying at the bedside with the patient, getting ready to draw the next Abg and looking at the patient's chest rise and vitals during the next 8 to 10 minute period. I am going to ask you to focus on the patient's chest and observe for any chest movements, and watch the patient's chest for a period of 8 to 10 minutes so that the patient does not have any chest rise. Sometimes you may be able to see the heart contracting inside the chest, which can be mistaken for a chest rise. So, please pay careful attention to see whether the patient is having adequate chest rise or not. So, we have done apneic oxygenation for 8 minutes. As you can see, patient has been disconnected from the ventilator. He has been getting oxygen 6 liters through the tubing. There has been no chest rise for the last 8 minutes. So, our goal is next to do the ABG, the second ABG after the baseline ABG, to document the rise in the PCO2. So, I am going to request my assistant again to come and draw the second ABG right now. So, why do we need an arterial blood gas to do an apnea test? We want to do a baseline ABG or arterial blood gas to document that the patient has got a normal PO2 and a normal PCO2, and then allow the patient to be apneic for a period of 8 to 10 minutes and repeat an arterial blood gas to document that during this time, one, the patient had no respiratory efforts, and because of that the arterial carbon dioxide levels started going up, and despite the arterial carbon dioxide levels going up above 60 millimeters mercury, patient did not have any spontaneous respiratory efforts. So, we are going to do a baseline ABG, an ABG in 8 minutes, compare both of them and make sure that the PCO2 has risen above 60 millimeters mercury, and despite which patient has had no spontaneous respiratory efforts. Then we can certify this patient as being apneic. After we did apnea for about 8 to 10 minutes, we drew this ABG and processed in the ABG machine. The key thing we are going to look at is the PCO2 level. Here you can see that the PCO2 level is 61. The baseline PCO2 level was 35. So, we need an absolute PCO2 level of 61 or a difference from the baseline of 20 millimeters mercury. As you can see in this patient, both the criteria were met, and despite reaching a PCO2 level of more than 60, this patient had no spontaneous respiratory efforts, and therefore we call him, we can declare him apneic and then proceed on with brain death declaration. We have done the baseline ABG, we have done apneic oxygenation for 8 minutes, and they have done a repeat ABG. So, we have looked at both the ABGs, and we know that the PCO2 has risen to more than 60 millimeters mercury or more than 20 above the baseline, which officially tells us that the patient is apneic despite an elevated PCO2. This terminates our apnea test, and now we will connect the patient back to the ventilator by just taking this oxygen cannula off and connecting to the ventilator. The important things to remember doing an apnea test is apnea test has to be terminated if the patient has spontaneous breathing efforts at any given point of time. So, if the patient has a spontaneous breathing effort, do not continue the apnea test. If the patient becomes hemodynamically unstable or goes into any kind of desaturation, please terminate the apnea test and do not wait for the 8-minute window. If the patient tolerates it, like in this particular patient, then we are going to connect him back to the ventilator after the second ABG is reviewed and the elevated PCO2 has been documented, then we terminate the apnea test. When we normally draw arterial blood gas in any particular patient, we need to be processing the blood right away. Most ICUs have a blood gas machine stationed there, so that this is not a logistical problem. However, if you do work in an institution where the arterial blood gas machine is either not physically present in the ICU or you have to transport the blood to a different facility, you need to make sure that there are certain things that you need to be aware of. First, make sure that there is absolutely no delay in sending the blood to that center. It needs to be done as soon as possible, especially in circumstances where the blood gas results determine the determination of brain death. 2, the blood has to be put in a bag of ice so that the metabolic activity of the blood stored in the syringe is not significantly high enough to alter the results of the blood gas results, and the blood gas should always be kept and transported in ice at all times and has to be moved to the place where the machine is there as quickly as possible. When we draw blood to process in the ABG machine, we need to make sure that there is adequate amounts of blood in the syringe so that the machine can recognize it and process it appropriately. Even small amounts of blood can be detected. However, it is better to draw at least 2 to 3 ml of blood so that we do not have to repeat this process again for lack of enough blood for the machine to read. So the recommendation generally is to take at least 2 to 3 ml of blood for an adult for us to process the arterial blood gas.